Congenital heart defects are usually divided into two categories based on the presence or absence of cyanosis, as well as by how it sounds on cardiac auscultation. Acyanotic defects cause left-to-right shunting and include four conditions: ventricular septal defect, or VSD, atrial septal defect, or ASD, patent ductus arteriosus, or PDA, and coarctation. Cyanotic defects present right-to-left shunting and include five conditions: tetralogy, transposition, truncus arteriosus, total anomalous pulmonary venous return, and hypoplastic left heart syndrome. Usually the diagnosis is then confirmed by echocardiography. An ECG should be performed as part of the initial workup. Chest X-ray is important when there's suspicion of heart failure, and sometimes a CT or MRI are done if the diagnosis is inconclusive. Rarely, cardiac catheterization and angiography is used if the diagnosis remains uncertain after non-invasive studies. Regarding infective endocarditis prophylaxis, it is recommended for high-risk individuals, those with a cyanotic congenital heart disease that has not been fully repaired, a congenital heart defect that's been completely repaired with prosthetic material, or a device for the first 6 months after the repair procedure, or repaired anomalies with residual defects such as persisting leaks or abnormal flow. Most heart defects can also be detected prenatally by standard obstetric ultrasound examination. However, small ventricular septal defects or atrial septal defects, minor valve lesions, partial anomalous pulmonary venous connection, and coronary artery anomalies are not often detected prenatally. The optimal gestation age for screening for structural fetal cardiac anomalies is 18 to 22 weeks of gestation, although in some cases it can be done as early as 10 weeks of gestation. In the first 2 days of life, a pulse oximetry saturation less than 90% in the right hand or either foot requires urgent echocardiography. If the saturation is 90% to 95% in either location, or if there's a saturation difference greater than 3% between the right hand and either foot, the test should be repeated hourly, and if it's positive 3 times, then echocardiography should be done. In acyanotic defects, the high-pressured left-sided systemic blood gets shunted to the right-sided pulmonary circulation. Because this extra blood is already oxygenated, there's no issue of cyanosis. But it does increase the pulmonary flow, and that leads to pulmonary hypertension. In some cases, over a long period of time, the pulmonary hypertension gets so bad that the pulmonary pressure exceeds the systemic pressure, causing reversal of blood flow from the right to the left side of the heart. This reversal is called Eisenmenger syndrome, and at that point, the deoxygenated right-sided pulmonary blood gets shunted to the left-sided systemic circulation, leading to cyanosis. In cyanotic defects, there's a defect which allows deoxygenated systemic venous blood to bypass the lungs and return to the body, leading to cyanosis. Ventricular septal defects are the most common pediatric heart defects. A small defect leads to minimal left-to-right shunting across the ventricles, and is not associated with any increase in pulmonary vascular resistance or with any symptoms. Larger defects can be heard on auscultation as a loud, harsh, or blowing holosystolic murmur, and are best heard over the lower left sternal border. There may also be a palpable thrill. The pulmonic component of the second heart sound can also get louder as a result of pulmonary hypertension, and because of the increased blood flow across the mitral valve, a mid-diastolic, low-pitched rumble at the apex might also be heard. Larger VSDs can cause a parasternal heave and a displaced apex beat. Over time, left heart failure might develop, leading to pitting peripheral edema, ascites, and liver enlargement. In terms of imaging, transthoracic echocardiography is best at estimating the position and size of the VSD, and Doppler echocardiography can assess the magnitude of the shunt. It is usually the first and only test needed to diagnose a ventricular septal defect. Next, a chest X-ray might show signs of cardiomegaly, an increased pulmonary vasculature, and ECG might show left ventricular hypertrophy in those with large shunts. Both X-ray and ECG are not diagnostic of a VSD, but can be part of the initial workup when other cardiac issues are suspected. Treatment of small VSDs is usually not required, because they often close spontaneously during the first year of life. Even if they don't, small, asymptomatic VSDs typically don't cause any problems. When there's a large VSD, a history of endocarditis, or left ventricle dysfunction, treatment consists of surgical or percutaneous closure of the VSD. In cases of severe pulmonary hypertension and Eisenmenger syndrome, closure of the VSD is not recommended, and instead, pulmonary vasodilators, such as bosentan or sildenafil, can be used. Next, atrial septal defects can occur in any portion of the atrial septum. A small defect is less than 0.5 centimeters in diameter and is associated with no clinically significant shunting of the blood, whereas a sizable defect is usually larger than 2 centimeters in diameter and can associate a large shunt and substantial hemodynamic consequences. On auscultation, characteristic findings include mid-systolic pulmonary flow or ejection murmur accompanied by a wide-split second heart sound in all respiratory phases, because the extra blood return during inspiration gets equalized between the left and right atria. The widening of the split is due to prolonged emptying of the enlarged right ventricle, which delays pulmonic closure. An additional short, rumbling, mid-diastolic murmur might be heard along the lower sternal border due to increased blood flow across the tricuspid valve. Over time, the individual might present signs of heart failure. In some cases, atrial enlargement leads to chest deformity with transverse depressions along the 6th and 7th costal cartilages, which are known as Harrison grooves. In terms of imaging, transthoracic echocardiography remains the preferred initial diagnostic modality in children, and transesophageal echocardiography in adults because it offers significantly more anatomic information compared with transthoracic echocardiography, especially when it comes to measuring the size and position of ASDs. Next, a chest radiograph could be performed as well, as it might show heart enlargement and increased pulmonary vascular markings. Additionally, ECG in those with large shunts can show a slightly prolonged QRS complex with a characteristic RSR or RSR pattern in V1 due to right ventricular hypertrophy, right axis deviation, or P waves taller than 2.5 millimeters, suggesting right atrial enlargement. Regarding treatment, small atrial septal defects frequently close spontaneously in the first year of life. Defects that are greater than 1 centimeter often require surgical or percutaneous closure. Next is patent ductus arteriosus, and that's when the ductus arteriosus stays open after birth. On auscultation, a continuous murmur with a machine-like quality is best heard in the second left intercostal space, soon after onset of the first sound. In those with large left to right shunts, a low-pitched mitral mid-diastolic murmur may be audible at the apex as a result of the increased volume of blood flow across the mitral valve. A systolic thrill, maximal in the second left interspace, may radiate towards the left clavicle down the left sternal border. Over time, a large PDA could lead to congestive heart failure, impaired growth, and bounding peripheral arterial pulses, and a wide pulse pressure due to runoff of blood into the pulmonary artery during diastole. Regarding imaging, echocardiography is the first step towards diagnosis, as it can visualize and measure the ductus, show left atrial and left ventricular enlargement in large defects, and masses the direction and volume of the shunt. Additionally, Doppler examination usually shows systolic or diastolic retrograde turbulent flow in the pulmonary artery, and aortic retrograde flow in diastole. Next, chest radiography might show a prominent pulmonary artery with increased pulmonary vascular markings and cardiac enlargement if the shunt is important. An ECG in older infants and children may demonstrate left ventricular enlargement with a deep Q wave and tall R waves in leads 2, 3, AVF, V5, and V6. Treatment of hemodynamically stable individuals consists of indomethacin, ibuprofen, and acetaminophen. Acetaminophen, for example, is administered intravenously 15 mg per kilogram every 6 hours for 3 to 8 days. If the PDA is hemodynamically significant despite pharmacologic therapy and results in increased respiratory support or renal impairment, they should be ligated surgically or occluded percutaneously. However, once severe pulmonary vascular obstructive disease develops, ligation or closure is contraindicated. And finally, coarctation is a narrowing of the aorta, which mostly occurs below the origin of the left subclavian artery at the origin of the ductus arteriosus. On auscultation, a short systolic murmur is often heard along the left sternal border at the 3rd and 4th intercostal spaces, which might be transmitted to the left infrascapular area and occasionally to the neck. A systolic ejection click may be heard if there is an associated bicuspid aortic valve. On examination, the classic sign of coarctation is a disparity in pulsation and blood pressure in the arms and legs. Normally, the femoral pulse occurs slightly before the radial pulse, but in coarctation, a radial-femoral delay occurs when blood flow to the descending aorta is dependent on collaterals, so the femoral pulse is felt after the radial pulse. Moreover, in healthy individuals, systolic blood pressure in the legs obtained by the cuff method is 10 to 12 millimeters of mercury higher than that in the arms. But in coarctation of the aorta, blood pressure in the legs is lower than in the arms. Over time, individuals might develop cyanosis, tachypnea, and signs of heart failure. Imaging-wise, the first step towards diagnosis is echocardiography, which can visualize the location of the coarctation alongside associated anomalies of the mitral and aortic valve. Next, chest radiography can show cardiac enlargement and pulmonary congestion, mostly in those with severe coarctation. Electrocardiography is usually normal in young children, but reveals evidence of left ventricular hypertrophy in older individuals. Treatment of mild cases is done with prostaglandin E1 infusion, which can open the ductus arteriosus, but also seems to relax the tissue of the coarctation segment. Definitive treatment is elimination of the narrowed segment either through surgery or via transcatheter techniques. Surgery requires removal of the coarctation segment and direct anastomosis of the normal aorta. The transcatheter technique utilizes balloon and stent angioplasty. So now, let's discuss cyanotic heart defects. First, tetralogy of Fallot has 4 components: pulmonary stenosis, a malalignment type of ventricular septal defect, dextroposition of the aorta so that it overrides the ventricular septum, and right ventricular hypertrophy. On auscultation, there might be a systolic murmur that is usually loud, harsh, crescendo-decrescendo, and most intense at the left sternal border, and is usually preceded by a click. The murmur is caused by turbulence through the right ventricle outflow tract, and it tends to become louder and harsher as the severity of pulmonary stenosis increases. In some cases, the P2 sounds might not be audible, and a systolic thrill may be felt along the left sternal border in the 3rd and 4th parasternal spaces. Over time, individuals might have a left anterior hemithorax bulge due to right ventricular hypertrophy and signs of heart failure. Often, cyanosis is not present at birth, but it occurs later in the first year of life. Older children who have not undergone surgery may have dusky blue skin, gray sclera with engorged blood vessels, and marked clubbing of the fingers and toes. Moreover, they present with dyspnea, which occurs with mild exertion like playing. Characteristically, children often assume a squatting position for the relief of dyspnea caused by physical effort. Paroxysmal hypercyanotic attacks, also called hypoxic or blue spells, are a particular problem during the first 2 years of life. Individuals become hypernic and restless, cyanosis increases, gasping respirations ensue, and syncope may follow. The spells occur most frequently in the morning or after crying, and can progress to unconsciousness and occasionally to convulsions or hemiparesis. Imaging-wise, the main study is 2-dimensional echocardiography, which confirms the diagnosis, establishes the extent of aortic override of the septum, the location and degree of the right ventricular outflow tract obstruction, the size of the pulmonary valve annulus, and main and proximal branch pulmonary arteries, and the size of the aortic arch. Next, chest radiography might show a classic boot-shaped heart and an enlarged right-sided aorta. Electrocardiography might demonstrate right axis deviation and evidence of right ventricular hypertrophy with prominent R waves anteriorly and S waves posteriorly, upright T wave in V1, and a QR pattern in the right precordial leads. The P wave is usually tall and peaked, suggesting right atrial enlargement. And finally, preductal and postductal, or right arm and either leg pulse oximetry, should be ordered if there's any suspicion of a congenital cardiac malformation. Treatment of neonates with severe right ventricular outflow obstruction, presenting with severe hypoxemia and cyanosis, consists of prostaglandin therapy to maintain ductal patency and pulmonary flow before surgical repair. Blue spells require a rapid and aggressive approach including knee-chest positioning to increase systemic vascular resistance, oxygen therapy to improve pulmonary vasodilation, and systemic vasoconstriction, intravenous fluid bolus to increase the right ventricular filling and pulmonary flow, morphine, IV beta blockers to help improve the right ventricular outflow obstruction by relaxing the muscle, and intravenous phenylephrine to increase systemic afterload. If heart failure has developed, digoxin and loop diuretics are a good pharmacological therapeutic option. The definitive treatment consists of complete surgical repair, which includes closure of the VSD and relief of right ventricular outflow tract obstruction. Second is transposition of the great arteries. In dextrotransposition of the great arteries, the most common type of transposition, the aorta is anterior and to the right of the pulmonary artery. Desaturated blood returning from the body to the right side of the heart goes inappropriately out the aorta and back to the body again, whereas oxygenated pulmonary venous blood returning to the left side of the heart is returned directly to the lungs. Thus, the systemic and pulmonary circulations exist as two parallel circuits. On auscultation, the second heart sound is usually single and loud, although in some cases it may be split. Murmurs may be absent, or a soft systolic ejection murmur may be noted at the mid-left sternal border. Over time, cyanosis and tachypnea might develop, usually within the first days of life. Hypoxemia is usually moderate to severe, depending on the degree of atrial shunting and whether the ductus is partially open or totally closed. Regarding imaging, echocardiography confirms the transposed ventricular atrial connections and the interatrial communication. It can also visualize the ductus arteriosus as well as any associated lesion, such as left ventricular outflow tract obstruction or a VSD. Next, chest radiography might show the classic appearance of an egg-shaped heart in some cases. Electrocardiography is often normal, but may show right axis deviation and right ventricular hypertrophy. Treatment begins with adequate oxygenation, prostaglandin E1 administration, which stabilizes the individual by attempting to keep the ductus arteriosus patent, and balloon atrial septostomy, which enlarges a naturally occurring hole in the foramen ovale between the left and right atria. Once the individual is hemodynamically stable, corrective surgery can be performed. There are currently two commonly used surgical procedures for dextrotransposition. Arterial switch operation, which is the standard procedure dextrotransposition without major pulmonic stenosis, and the Rastelli procedure, which is indicated in those with a large VSD and pulmonary stenosis. Okay, so third is truncus arteriosus, or common truncus, where a single common blood vessel comes out of the heart instead of the usual two vessels, the main pulmonary artery and aorta. This leads to the mixing of the systemic and pulmonary venous blood flow as the single trunk receives output from both ventricles. On auscultation, there's usually a loud and single second heart sound and an ejection click. A grade 2 systolic murmur might also be audible along the left sternal border, alongside a mid-diastolic mitral flow murmur at the apex due to increased pulmonary blood flow. With truncal valve insufficiency, a high-pitched diastolic decrescendo murmur might be detected over the mid-left sternal border. Moreover, peripheral pulses are accentuated and often bounding, and the pulse pressure usually is increased because of runoff into the pulmonary vascular bed during diastole. Over time, infants usually show mild cyanosis, respiratory distress, and symptoms and signs of heart failure in the first few weeks of life. Imaging-wise, postnatal diagnosis is made by echocardiography, which can identify the single overriding great vessel arising from the heart, typically from a subcostal long-axis view. It also provides information on the cardiovascular anatomy and can spot any additional defects. Doppler techniques such as color mapping can quantify the degree of truncal valve regurgitation and stenosis. Next, chest radiography typically shows cardiac enlargement, increased pulmonary vascular markings, or a right aortic arch in approximately 1/3 of the cases. ECG is nonspecific and may be normal, but sometimes it can show left or right ventricular hypertrophy, or a combination of both. In those with heart failure related to pulmonary overcirculation, QRS and P wave voltages can be increased. Treatment includes diuretic therapy to reduce the preload by promoting natriuresis, inotropic agents like dopamine and dobutamine to improve myocardial contractility, angiotensin blockade and angiotensin converting enzyme inhibitors to reduce the afterload, and non-invasive positive pressure ventilation in case of respiratory distress due to pulmonary congestion. After stabilization, the definitive treatment consists of primary surgical repair during the neonatal period. Fourth is total anomalous pulmonary venous return. Normally, oxygen-poor blood returns to the right atrium from the body, travels to the right ventricle, and then it's pumped through the pulmonary arteries into the lungs. Oxygenated blood returns to the left atrium from the lungs through the 4 pulmonary veins. It makes its way through the left ventricle and is pumped through the aorta out to the body. In total anomalous pulmonary venous return, the 4 pulmonary veins are connected somewhere other than the normal connection to the left atrium, most commonly to the superior vena cava. On auscultation, the only findings might be a widely split second heart sound, sometimes with a loud pulmonary component, and a grade 2 to 3/6 systolic ejection murmur audible along the left sternal border. A mid-diastolic tricuspid flow murmur may be audible at the lower left sternal border. Over time, if the connection is obstructed, important cyanosis, respiratory failure, and shock develop. These individuals have elevated pulmonary artery pressure and edema, resulting in respiratory distress, tachypnea, and diminished systemic output, resulting in hypotension. This is similar to respiratory distress syndrome. However, in respiratory distress syndrome, the symptoms begin immediately after birth, whereas in obstructed total anomalous pulmonary venous return, they are slightly delayed, typically after the first 12 hours of life. Those with unobstructed lesions may only have subtle cyanosis immediately after birth. Regarding imaging, echocardiography is the first technique used for diagnosis. It can detect normal pulmonary venous connections to the left atrium, a common ascending collecting vein along with the dilated superior vena cava, a direct connection between the pulmonary venous system and the right atrium, dilation of the right atrium and ventricle, and right to left interatrial shunting. Next, chest x-ray might show a small heart and severe diffuse pulmonary edema where there is pulmonary venous obstruction. Otherwise, there is cardiomegaly along with increased pulmonary vascular markings. In other cases, the anomalous venous pathway creates a second round shadow above the heart, resembling a snowman. ECG shows right axis deviation, right ventricular hypertrophy, and occasionally right atrial enlargement. Treatment consists of surgical repair consisting of a wide anastomosis between the pulmonary venous confluence and the posterior wall of the left atrium. Neonates with total anomalous pulmonary venous return with obstruction require emergent surgical repair. In older infants, heart failure should be treated first, followed by surgical repair as soon as the infant is stabilized. And finally, hypoplastic left heart syndrome consists of hypoplasia of the left ventricle and ascending aorta, maldevelopment and hypoplasia of the aortic and mitral valves, an atrial septal defect, and a patent ductus arteriosus. Because the left ventricle, mitral valve, and aortic valve are hypoplastic, oxygenated blood reaching the left atrium from the lungs is diverted across the atrial communication into the right heart, where it mixes with desaturated venous blood. This results in desaturated blood that exits the right ventricle through the pulmonary artery to the lungs and through the ductus arteriosus to the systemic circulation. On auscultation, typically, no murmur is heard. The second heart sound is loud and single due to the absence of the aortic valve component and the associated pulmonary hypertension. In some, a pulmonary flow murmur may be present alongside a systolic murmur of tricuspid regurgitation. Over time, as the ductus arteriosus begins to close during the first 2 days of life, cardiogenic shock develops with symptoms like tachypnea, dyspnea, weak pulse, pallor, cyanosis, metabolic acidosis, and oliguria or anuria. When systemic circulation is compromised, coronary and cerebral perfusion may be severely reduced, leading to symptoms of myocardial or cerebral ischemia. Regarding imaging, diagnosis is by emergency echocardiography, which shows a small left ventricle, abnormal mitral and aortic valves, and hypoplastic ascending aorta. Next, chest x-ray might show cardiomegaly, pulmonary venous congestion, or pulmonary edema. ECG might detect right ventricular hypertrophy and diminished left ventricular forces, though it may be within normal limits for a neonate. Treatment includes stabilizing the individual. Then, prostaglandin E1 is infused to prevent closure of the ductus arteriosus or to reopen a constricted ductus. And finally, definitive treatment consists of staged surgical correction or heart transplantation. Okay, quick recap. Ventricular septal defects present a loud, harsh, or blowing holosystolic murmur, which is heard best over the lower left sternal border, a second heart sound with an increased pulmonic component, and some might present a mid-diastolic, low-pitched rumble at the apex. Diagnosis is confirmed by transthoracic echocardiography, and treatment of large defects consists of surgical or percutaneous closure. Atrial septal defects present a mid-systolic pulmonary flow or ejection murmur and a widened split-second heart sound in all respiratory phases. Echocardiography confirms diagnosis, and defects that don't resolve spontaneously in the first year of life require surgical or percutaneous closure. In patent ductus arteriosus, the classic continuous murmur is machine-like in quality. It begins soon after onset of the first sound and is usually located at the second left intercostal space. Echocardiography can show the size and position of the duct, and if the PDA is hemodynamically significant, it should be ligated surgically or occluded percutaneously. Coarctation presents with a short systolic murmur heard best along the left sternal border at the third and fourth intercostal spaces, a radiofemoral delay, and higher blood pressure in the arms than in the legs. Additionally, individuals might present with cyanosis, tachypnea, and signs of heart failure. The coarctation segment can be visualized by 2D echocardiography, and treatment consists mostly of prostaglandin E1 infusion and elimination of the coarctation through surgery or via transcatheter techniques. Next, tetralogy of Fallot presents with a systolic murmur that is loud, harsh, crescendo-decrescendo, and most intense at the left sternal border. Some might present with hypoxic spells. Two-dimensional echocardiography establishes the diagnosis, and treatment consists of managing blue spells, which requires knee-chest positioning, oxygen therapy, intravenous fluid bolus, morphine, intravenous beta blockers, and intravenous phenylephrine. The definitive treatment consists of complete surgical repair. In detransposition of the great vessels, the second heart sound is usually single and loud, although in some cases it may be split. Murmurs may be absent, or a soft systolic ejection murmur may be noted at the mid-left sternal border. Echocardiography is diagnostic and confirms the transposed ventricular arterial connections. Prostaglandin E1 and balloon atrial septostomy stabilize the individual, who can then get corrective surgery of the defect. In truncus arteriosus, there's a loud and single second heart sound, an ejection click, a grade 2 systolic murmur, and a mid-diastolic mitral flow murmur at the apex. The peripheral pulses are accentuated and often bounding, and the pulse pressure is usually increased. Echocardiography can identify the single overriding great vessel and spot any additional defects. Treatment encompasses initial medical management to stabilize the individual and primary surgical repair during the neonatal period. In total anomalous pulmonary venous return, the only findings might be a widely split second heart sound, sometimes with a loud pulmonary component, and a grade 2 to 3/6 systolic ejection murmur audible along the left sternal border. Echocardiography can detect abnormal pulmonary venous connections, a common ascending collecting vein along with a dilated superior vena cava, dilation of the right atrium and ventricle, and right to left interatrial shunting. Treatment includes a surgical repair consisting of a wide anastomosis between the pulmonary venous confluence and the posterior wall of the left atrium. And finally, in hypoplastic left heart syndrome, typically, no murmur is heard. The second heart sound is loud and single, and in some, a pulmonary flow murmur may be present alongside a systolic murmur of tricuspid regurgitation. Diagnosis is by emergency echocardiography, which shows a small left ventricle, abnormal mitral and aortic valves, and hypoplastic ascending aorta. Treatment includes stabilization, prostaglandin E1, and staged surgical correction or heart transplantation.